evening, everyone from India. I wholeheartedly welcome you all to Global Interdisciplinary Summit 2020, co-hosted by Global Outreach Medical and Health Association. So on this platform, we are having beautiful speakers with us with their beautiful sessions taken. So with this, for today's third session of the day, we are having Dr. John with us. So speaking about him, Dr. John's Dr. John's involvement with the postgraduate periodontic program at the University of Buffalo, CUNY, speaks to the depth of his knowledge and experience in the scientific investigation of gum diseases. As a research assistant professor at the university, Doctor is involved in a major study comparing the pinhole surgical technique, his invention, to the standard treatment for gum recession called the connective tissue graft. Doctor will be one of the authors of this new study. The main reason Doctor has served as the faculty at the USC School of Dentistry that he believes the best way to learn more is to teach. He incorporates stringent academic standards of diagnostics and treatment in his private practice. For example, he examines each patient for every relevant aspect, which generally takes 1 hour or more. Doctor always offers patient treatment plans that will suit their lifestyle, finances, and their immediate and long-term needs. His introduction as the Master of the Academy of General Dentistry is just one example of the many awards and accreditations Doctor has received over the years. He has a widespread reputation as a lecturer and teacher both to undergraduate and postgraduate students. So speaking about him, I welcome Dr. John with us for the session, and I would request all the participants to register with the given links that are there in the description box for all the participation certificates, CE certificates, and speaker schedules and more. So kindly sit back and enjoy the doctor's session. Doc, you can give it a start.
Hello, everybody. Thank you for joining this World Global Summit on this very exciting subject that has to do with treating receding gums, a very, very common phenomenon that we see in our practices. And thank you for joining us. I am broadcasting from beautiful Southern California on the wonderful sunny morning. So from California, good morning, good day to everyone around the world. I'm very excited and very honored and very privileged to be able to share this new technique with you. In my opinion, seeing the results of what we've done in the last 5-6 years, I believe pinhole surgical technique will become standard universal in the next 5 to 10 years, where most of the dentists around the world will know what it is, and many, many dentists will be practicing it, using it to cover receding gums, to use this technique to actually replace the typical class 5 composite fillings. So you'll be doing less and less composite fillings and be able to do pinhole surgical technique where the decay portion of the root or the receded gums are permanently taken care of. So we will talk about the long-term results of pinhole surgical technique and how this has come about. So let's put everybody on the same page to start with. Let me play a video of the comparison between conventional gum grafting, the subepithelial connective tissue graft, and the Chao pinhole gum rejuvenation technique, or the Chao pinhole technique.
Introducing Chao Pinhole Gum Rejuvenation's pinhole surgical technique. Before, conventional gum grafting required cutting tissue from the roof of the mouth.
So you need to share your screen.
Yes. So,
can you not see the screen?
So we're not able to see the screen.
okay, let's start again.
Okay, hold on. Okay, how about that?
So we're not able to see.
Can you see us right now?
No, sir. So, yeah. Yes, sir.
Are we
Open
on?
up the presentation. Yes, sir. Perfect.
Okay, we'll go back to the animation.
Yes, sir. Perfect.
Okay.
Okay, are we on right now? Everybody can see this?
Introducing
Yes, sir.
Chao Gum
All right, very
Rejuvenate.
good. Okay, so let me just describe the conventional way of treating receding gums. It's called subepithelial connective tissue graft. You retrieve a specimen from the palate and you put it under the flap where the recession is and suture it up. This is conventional gum grafting technique done all over the world right now, except in certain parts of United States, actually all of the United States and basically around the world. We have the new pinhole surgical technique, or the Chao pinhole gum rejuvenation technique. A pinhole is made in the mucosa above the recession, and through special instruments, a full thickness flap is raised. There's no splitting the tissue, and the tissue is released from the roots and from the bone directly, along with the periosteum, and the tissue is moved to where it belongs, and collagen is put in through the pinhole. This collagen creates tension that would stabilize the flap. So that is, in essence, the basic concept behind the Chao pinhole surgical technique and the pinhole gum rejuvenation, which is a synonym. All right, let me show you then a 7-minute operation that I actually did some years ago. And this is a 1-minute edit of a 7-minute operation. So this doesn't take long to do, folks. Now, once you get used to it, it becomes second nature. It's like doing a filling, except this one takes only 7 minutes. A pinhole is made about 8-9 millimeters from the gum line. A special instrument goes right down to the bone, elevates the tissue completely, entirely, along with the periosteum, from the bone and from the roots, using different directions, and go beyond the teeth, the tooth that I'm treating, go some teeth distal, some teeth mesial, release the tissue completely. Once it's released and advanced, then strips of collagen is placed under the papilla and under the flap, and this stabilizes the flap. So there's no use for scalpels nor sutures. Because it is free of suturing, it looks very, very nice. And it heals very, very fast. This, ladies and gentlemen, is what it looks like immediately after the 7-minute operation. The gum line is way compensated, very, very compensated, and you see how far down it is. And look at what it looks like the next day. So therefore, that pinhole, or whatever that the aperture is, it does not require suturing. It basically heals up by primary intention within, most of the time, about 24 hours. And this is what it looks like a week later. And this is what it looks like about, 3 years later. Okay, so that's basically the concept. The nuances, the techniques, and that's perfected over the 20 years since I first came up with this concept, and that will need to be taught in a hands-on course. And the instrumentation is quite sophisticated. It's very simple in the way it looks now, but it went through many, many generations of changes over the years, and then the ones we use now are very convenient to use and has been proven to be effective for a long time. Now, before publicizing and bringing this technique to the attention of the dental world, I did a 33-month study of this technique with documentation sufficient to show the editor of the International Journal of Periodontics and Restorative Dentistry that this is a valid technique. Study models, photos, and all the documentation that was necessary was given to the editor Myron Evans, who then published this pinhole surgical technique in his journal in 2012. Now this is the before. This happens to be a seminal case. This is before, and down below the picture is the after. This is about 30 months, this particular case. Now what's interesting I want to show you is that this same case was then rephotographed in 2016. Now we have actually pictures from 2020, but we don't happen to happen this time, but this shows how this technique works. Look at that. Look at the upper left cuspid area. Look at the tissue above the roots of the upper left cuspid and the upper left lateral incisor. Notice there's no appearance. There's no evidence of any attached tissue. No keratinization. Basically, this is a class 2 Miller, has no attached tissue, and yet tissue appeared from out of nowhere. This is something that's quite phenomenal. This is something that that is not known in the world of periodontics, where you create new keratinized tissue from no tissue at all. So we're gonna change it a little bit so I can actually get the cursor to show up. Here we go. So let's move this a little bit, so you can see how this is how this new tissue has come about from no tissue here to tissue here. This is one of the most amazing things about the pinhole surgical technique, is that we can regenerate tissue regardless of how much loss of tissue we have to begin with. As long as the papilla is there, then tissue will grow. All right. So, and it is for many recessions all at one time. With the excellent subepithelial connective tissue graft invented by Dr. Langers, whom I've met and have great respect for. That method is wonderful for doing 2 or 3 teeth at a time, even maybe 4. But when it gets beyond 4, you have to use something else. And one of the 3 methods that's available right now, that's published and peer-reviewed and practiced by large numbers of dentists, is the pinhole surgical technique. All right, so let me shift to the next slide. Okay, so now this particular study that was published in the International Journal of Periodontics and Restorative Dentistry consists of 43 patients, 121 sites, of which 85 were class 1 and class 2. Class 1 and class 2 cases are recession cases where the papilla is intact. And there's a variation in the degree of recession. For class 2 cases, there's no attached tissue. For class 1 cases, there is attached tissue. So the more severe cases are class 2, you can say, and the less severe cases are class 1. But class 1, class 2 cases were about 85, and the rest were class 3 cases. And the mean recession, these are not just simple cases where you have 1 or 2 millimeters of recession. The average recession was 3.4 millimeters. All right, so what is the result? The result was that we were able to prove that the average 81.2% of the time, we were able to get 100% coverage. So of the cases that you saw, which were like this, 80% of the time we were able to get complete coverage. And when we didn't get complete coverage, most of the roots were covered. So 94% plus or minus, let's say 14, you can have a good average of root coverage is 80%. So that's not bad in comparison. And of course, patient satisfaction, patients being happy with the results is just very, very high, because when you have done the pinhole surgical technique, the patient smiles and look in there. There's no sutures. There's nothing showing that there's even any surgery at all, because it's all red or swollen. But outside of that, patient see the marvelousness of this technique in that there's no signs of infection. And because we only go through a pinhole, there's no incision. And because we're not splitting the tissue, we're not cutting into vessels, we're not cutting into nerves, we're going down to the bone. Now remember now, there's hardly any connection, vascular connection, blood supply going from the bone to the soft tissue. So you're not depriving the tissue of very much of its blood supply, and therefore the pain is minimal. The pain is average less than 2 over-the-counter pain pills per operation. Whereas by contrast, other techniques, they're talking about 8, 9, 10, 12 over-the-counter pain pills. All right, so now I do want to quickly mention there's exciting study being conducted, actually just finished at the University of New York and located at Buffalo. It compares on a split mouth basis, the pinhole surgical technique and the subepithelial connective tissue graft. So the same patient will get both techniques, and it's randomized in the sense that there's no set way of picking which side will be done with the pinhole and which side will be done with the graft. And the examiners are blinded as to what technique was used when they interviewed the patient as to symptoms. So it's a double-blind, randomized clinical trial conducted by a prestigious school of dentistry in New York. And this has been going on for almost 2 years. So I'm told that an abstract of this split mouth study will be presented at the annual meeting of the American Academy of Periodontology this coming October. So now what does this? So now I was able to present the preliminary results of this particular study while I was a guest speaker at the annual meeting of the American Academy of Periodontology in Vancouver, October 2018. And in this particular meeting, I was able to present preliminary results of this particular study, and it showed that both techniques was able to get gingival correction, get gingival augmentation to the same degree. Both were about 3 millimeters in average to start with, and ended up with just about the same amount of coverage. So this shows that the results of the two techniques are about the same. So the percentage of patients achieving full coverage was still around 80% for both techniques. The interesting difference was that pinhole took about 24 minutes, whereas grafting took about 47 minutes. And the difference in time is basically suturing time. So when there's no suture, you save a lot of time. This makes it a lot more cost-effective, and of course time-effective, and therefore this benefits the patient as well, of course, as the doctor. So by random, 29 patients were asked this question: if you had gum recession and you were to have it done again, which method would you choose? 21 of 29 patients prefer the pinhole surgical technique. So this will be basically published in the next 12 months, the abstract being presented in October at the annual meeting of the American Academy of Periodontology. So you can see the science is now backing up the effectiveness of the pinhole surgical technique. And this is why you can look forward to the pinhole surgical technique being universally accepted and practiced, not only by general practitioners, of which I'm one, but by periodontologists, periodontists. So this is upcoming, and this is the wave, and this is not only for situations where you have recession or decay around roots and so on, but this is also for cases where you have recession after implants. Now, there's no study right now that tells you how effective this is, but anecdotally, we have very good results in certain cases of where there's recession around implants. This is just an example of a case where implants were involved, and pinhole surgical technique was able to save the day. All right, so now let's talk about a little bit more now of why it works. How come you can do all this? How come you can do so many teeth all at one time? Well, we have a lot of tissue here. So we're not trying to struggle to cut this tissue and suture it and try to nurse it downward. We have all this tissue here, so we can release all this tissue and bring it down. Suppose we're able to bring it down to here. Would you believe actually in about 40 minutes or so for this case, the tissue can come down to about here. And then it's not sutured, it's bolstered, it's augmented by strips of collagen, and then it heals. What am I doing wrong here? Okay, so here what this looks like after about 40 minutes later, same day, this is the pinhole, 2 pinholes here, the tissue is way down here. This is plumped up with collagen. As this heals, you'll heal to the maximum amount that the body will allow it to, controlled by the phenotype and of course the genotype. So this is what it looks like 2 weeks from the time of the surgical technique. You can see why it doesn't matter how much recession you have. We have just too much tissue here, and not to be able to make it to give you full coverage. You can say, well, how come you only need to put collagen in? Why is it collagen makes it stay? Well, that's because remember in your freshman year in dental school, you learn about the different gingival fibers that holds the gingiva tightly against the root, and the different ones that connects the root to the gingiva, and connects the root to the next tooth, so on and so forth. Go by different names, but the one that you want to remember is the circular fiber. It goes round and round each root, thousands of them, and is very elastic, and it compresses the gingiva against the root. Now, what we do is we extend it, we release it from its underlying structures, and then we plump it up with collagen, and now it gets elastic. And the tension created by the additional membrane that resorbs completely in 6 months then allows us to use collagen to keep the gums down. So now we don't have to suture. You know what suture can bring, right? Suture has different complications. One of which is possible seepage, infections, or too much tension. The different variations of complications associated with sutures. So we're able to avoid that. And there's another advantage in terms of pinhole surgical technique in that we can minimize trauma. The more we minimize trauma, the better the results, as you know. All right. Something else that works for us: the muscle pull. Buccinator originates from the alveolar ridge on the upper and the alveolar ridge on the lower, and it pulls forward and downward on the upper and upward and forward on the lower. So as soon as we have released the tissue from its attachment to the alveolar ridge, guess what? Muscles pull the tissue downwards. So we don't have much to do. We don't have to fight against this pull by trying to suture it. And we allow the muscle pull to work for us. It's not only just a buccinator, it's also something else. is the strongest muscle pound by pound in the body, the masseter, and that attaches, originates from the upper alveolar ridge and attaches to the lower mandibular alveolar ridge. So the masseters are bringing this flap down, and the masseter is pulling the flap up on the lowers. So everything's working for us. I jokingly tell my classes that the force is with us when we do the pinhole surgical technique. Now, the pinhole surgical technique is unique in that, with the subepithelial connective tissue graft, but how do you do the full mouth? Do you have enough tissue on the palate? So let's say do the whole upper arch, and then do you have enough tissue to do the lower arch all in one time? Of course not. So there are three methods right now that it is recognized by the AAP, the American Academy of Periodontology. The number one is the tunnel using allografts. Number two, the Vista technique, where you make a vertical incision and put a membrane in, a suture, and suture it all up with composites put on the teeth. So now the pinhole surgical technique comes, and without suturing, without composites, without much ado, go from here all the way across and take care of this problem, and come down here and take care of this problem, all at one session. It took we did the upper in one session, same day. We gave the patient a little break. He had a little lunch. Then we came back and did the lowers. So it's unique in that you can do that. Now, what's really exciting, everybody around the world, is that you have to put fillings in here, right? Right now, put fillings in, and then we replace it. The gums keep receding, then we put more fillings in. This is a long-term, permanent solution to decay, to recession. You don't have to put fillings in here. We can bring the gum line down and have the gingival tissue regenerate, attaches into the root. It becomes a permanent solution to this problem, all around, all at one time. So granted, very few people can do it all at one time right in the beginning. But as you practice, you get better and better at it, you'll be able to do what it is shown here. All right, so this is just the start of the operation. We went in and we released the tissue, starting from over here, and went all the way around, see how far we can bring the tissue down. It doesn't matter how steep the recession is, we have enough tissue to cover, any kind of recession, given some limits, of course. All right, so this is just a little tidbit of what it looks like to take care of a case like this. All right, so what about long-term cases? We're going to show you why long-term cases does work, but this is an example of a case that was done in 2005, 5 years after I started devising this technique. And see, this is 11 years later, and it's still doing well. Interestingly enough, this is a 80-some-year-old woman who had a bridge and that she didn't want replaced. So I say, you know what, let's take out the composite, let's do the pinhole surgical technique and see what happens. Well, lo and behold, 10 years later, there's no decay, and then we still have our bridge intact. In the meantime, she was diagnosed with diabetes. Nevertheless, it worked. So long-term results are there because of what? Because of what I told you, we have enough tissue to work with. And we minimize the trauma to the teeth, and we're able to gather enough tissue to cover the roots to overcompensate for shrinkage. This is another case. Look at the upper left first bicuspid, and this is a 12-year case. Now, this is a case where the patient had a smile like this. And when we're all done, he has a smile that looks at the right side. So not surprisingly, this very handsome young man actually got married 6 months later. So he looks like this on the right today, and not his old self, the left side. Now, you say, well, it works on the uppers. What about the lowers? Don't you get nervous when you work around the second bicuspids, when you do surgery there, or even do root canal. You see the tip is right next to the mental foramen, or when you do implants. You always fear that, aren't you? And most people are. So in what way does pinhole surgical technique make this easy? Let me show you how. Pinhole surgical technique, we basically keep the instrument up on the top. Can we get the cursor to work again? Let me make a little manipulation here so I can get the cursor to work. All right, so I can point things out. Here we go. Here we go. Now, the pinhole surgical technique, which I'll show you next in the video, we put a pinhole here, and the instrument works over here, which is constantly pushing up. We don't dissect our way down. So we're perfectly safe when we work in this area, and we don't have to worry about this particular structure. All right, so now we put a pinhole over the right cuspid. There's no mental foramen there, and the instrument is constantly pointing upward. You see that? The instrument is always up here. The instrument does not go down. See that? And then we release the tissue from the bone. We don't split the tissue. We basically lift it up, lift it up, lift it up. So the instrument being up there, the tip of the instrument is up here, and the mental foramen is down here, you have nothing to worry about. So if you want a safe technique, you don't want to have to dissect your way downward, and you want to cover the roots here, pinhole surgical technique is a technique that could not be safer for you. You never have to worry about damage to the mental nerve. All right. So now, interestingly enough, tell me why there's no bleeding here. There happens to be a cadaver. This is one of the teaching tools that we use to teach with. We actually will show you this now. Okay, so we'll play this for you. A pinhole is made in the mucosa, about 8-9 millimeters apical to the background noise from the class. So let's just take the noise down. And this instrument allows me to go down to the bone and elevate the tissue. Somebody else is holding the lip down. I'm using 2 hands, and this instrument is made for me to work from above the patient. And there was certain manipulations, certain turning of the blade, certain ways of keeping the blade down against the bone to prevent perforating the tissue. And this is in about 15 minutes, we're able to release all this tissue here. So let me advance it so we don't bore you with this. Okay, and let's go forward a little bit more.
So they have position.
And some of the instruments are longer because we have to be able to reach further away. All right, so 15 minutes goes pretty fast.
I can actually narrate it, but you know.
All right, so, but it's a very easy.
From right behind you on the left side here. We're gonna have 2 cameras.
It's an enjoyable technique, and like I said, this is coming. This will be universal in the next 5-10 years. I think most people will say, why not do the pinhole? Why put a filling in when you can permanently take care of the problem without having to go back there and put composites all the time? So this is coming in from the left side. You see how we were able to advance the tissue all the way up here.
Right here.
Now we put collagen in, and put so much collagen in that the vestibule is practically.
So we can do 2 at a time, no big deal. We'll do 2.
All right. So there's enough collagen here to keep the gums from going down. It's overcompensated, and so we get our results. See, this is how far it was down here before, now it's way up here. And this overcompensation allows us to get the best possible healing in all cases. Now here, this is a interesting video, and that's taken from the Doctor Show. The Doctor Show is very popular in the United States, and I understand actually goes around the world. I've heard patients who told me that they saw a doctor who they told me they saw it in Dubai and even Australia. So let's play this for you, just for interest.
57 minutes. You'll do 10 teeth. Looking really nice. It'll be a total change.
Ready? Yeah. Oh my God. That's way different. I'm sorry. I'm so happy. I'm so excited about this. This is kind of picture.
Rocio is here with us today, and that was an emotional moment for you, wasn't it?
It's amazing. I can't believe it.
You show that smile off. Just smile at that camera, because this is a transformation that goes beyond just a healthy mouth. This is emotionally a big deal for you.
So you have your moments. When we have our moments sometimes when we have patients reacting in such a nice, moving way to what we do. And this is what being dentist is all about, isn't it? When we can do things like this for our patients and get this kind of satisfaction. So, all right. So this is Lucille. This is the lady that you saw in the video. This is before. 55 minutes later, this is what she looks like, and this is what she looks like nearly a year and a half later. Okay, you can say, well, what about you're the only one doing it? And right now we've trained over 3,300 dentists around the world, from Korea to Inner Mongolia to Dubai to Iraq to Iran to Italy and UK, South America, and Japan, Asia, and China, all around the world. So people are doing this, and so it's just not me. It's not me. This happens to be one of the doctors who had done this in the beginning. So he's having 4-year cases now, and so let me show you one of his cases, Dr. Andrew Moman. All right. So good. So look at this amalgam here. Can you change the cursor for me, please? I'm having a problem with the cursor working. All right, here now we got a cursor working again, and so you have this Dr. Moman's case. This is a tree in the bridge. This is a filling. He's going to replace this crown, and put an implant right here. Okay, so let's see what he does. This is the day of the surgery. You remove all the amalgam, remove all the decay, and from a pinhole that's made over the cuspid, because as you release it, it goes forward. So the pinhole originally was over here. He did what I showed you on the other video. The instrument is always up here. It's always up here. It's always up here. It's always up here. It never goes down to where the mental nerve is. It's such a safe, easy, enjoyable technique for you to do. So it goes up, 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 and this is what it looks like when he got done. Isn't that impressive? And this is 4 years later. This is what it looks like. This is an implant. This is, of course, a new crown, and this is a new crown. So he was able to maintain the tissue and do a beautiful implant here, and basically took care of this problem here. I don't think he did a new crown here. All he did was remove the amalgam and brought the gum line up. Or am I wrong? I think that's what he did. He didn't do a new crown here. All right. So isn't that cool? No, he did a new crown. This is a new crown. All right. So this is really, really nice. And again, you have a Frenham pole, and you have all different types of conditions. But Dr. Franklin, a periodontist, was able to do this case and not have to graft. If you graft it, you have to do it in 2 sessions, right? Grafting for this part, grafting for that part. And with this, he was able to do it in 1 session and serve the patients in a way that grafting, which is very good at, that does not work. And you have a exostosis here, a bone protuberance that he was able to overcome through the use of the pinhole surgical technique. So no frenectomy, everything up the way it's supposed to. Dr. Zadell, a wonderful photographer. Look at that. Look at this here, and look at this here. And this is what you can expect when you do work like this. This is bread and butter here. This is very basic. You see this case. Don't you see this? Don't you see this everywhere in your practice? I bet you see 2 or 3 of these cases every day, and because you don't have the means to very easily, conveniently, painlessly do this, we basically ignore it. And I did the same thing. I basically ignore it. And if you want something done, you put a filling here, and if you really have mastered the skill of doing connective tissue graft, it is a wonderful technique. It takes a lot of training, sophistication, and to do something like this. In fact, Dr. Zadell is a periodontist. Now, nearly all that he does is pinhole. He does not use the subepithelial connective tissue graft, except to a very minimal cases now. So many periodontists use pinhole extensively. Others use a little less, depending on personal preference. All right, here's another case, Dr. Nemeth, very, very well known nationally in the United States and all around the world. And these are some of his cases. And he says fully half his practice now is doing pinhole for aesthetic reasons. So this is one of the cases that he posted on the Doctor's Forum. From here to here, in one sitting, no grafting. From this actually was previously grafted. Previously grafted, and then he was able to go in there and raise it and make it look like this. All right, so now I'm finished with my presentation, and I'll be happy to entertain any questions that the audience has.
Okay, thank you so much, sir. So thank you so much, sir. That has been an amazing technique, I would say. Actually, I aspire to be a periodontologist, first of all. So for me, it was actually an inspirational technique. Moreover, you're not going for any surgical thing, people who are actually afraid of blades, and there you can use it. It's quite, motivational for patient, as well as, like giving them no pain, first of all. So I actually love the technique for sure. So I am piled up with some questions. So
Sure.
First one is, what do you call that instrument which you use?
Well, we call it the pinhole surgical technique instrumentation. That's basically it. We call it by different names, papilla elevators, straight instruments, different names that we actually call it by. Each instrument has a name. So it's
Okay.
one a short, 2 a long. So there's a different names that we give the instrument.
But what I feel is, when I was seeing that video, it works like being like the tip is quite similar to a scaler, the hand scaler, right? Is that so?
It has the hand scaler type of configuration, but the blades, the angles are different. And
Okay.
at the beginning, when I was experimenting with different instruments, I realized that none of the instruments have the angulation
Okay.
and length and the rotation that were needed to be able to work from a pinhole, from a hole extending all the way around. So, and nothing really fitted. This is why I had to go to the trouble. Took about 6-7 years to come up with the right instruments to be able to do this in the way that we're doing it now. So, but you're absolutely right. If you look at carets and so on, they're a little different. So when we were able to we really questioned on that. Actually, the question that they asked me was asked by the patent examiner. Oh, we lost our image here.
No, no.
There. Okay, so I'm looking at a blank. I'm looking at a blank here. Okay, so if you can see me, that's fine. And so actually, we were able to very obviously show that the carets, the urbans, and all the other instruments which are available cannot do the job that's required if you want to do the pinhole surgical technique. Okay, I think we're frozen here.
Yeah.
Okay.
Okay.
We're still on you right now?
Yes, I'm like able to see you.
I hope that answers the question. If not, you can ask again.
Okay, so you've got the instrument customized.
Yes, it's invented, it's patented. And,
Okay. Okay, so you've not named it. You've just named it as pinhole instrument.
Yes, but it has special names. Each one has a special name.
Okay, you have set of instruments. Okay.
So pinhole instruments.
Okay. So moving on to the next one. With this technique, do the gingiva recedes down on its own, or we are pushing it downwards, or there's the force of the muscle which you were talking about, the buccinator?
Yeah. Well, what you do is you release it from its attachment to the bone into the roots. Now it's just free floating.
Yeah.
Okay, it's no attachment at all. If you because it's so passive, you actually put it where you need it, which is about 3 or 4 millimeters coronal to the CEG. It basically will go there and stay there passively all by itself. You don't have to push it. It's very passive. There's no tension at all. This is why we make it go mesial and distal quite a distance. Everything just fall by its own weight practically on the uppers. And then we stabilize that passive position and putting collagen underneath the papilla and underneath the bone. So there's no pushing, there's no tension at all. It's basically tension-free. Tension-free.
Okay, so collagen is basically having the role of stabilizing that the gingiva, which is all free. So collagen is the one which is stabilizing it at that position, right?
Yes. What stabilizes is the collagen building in. Now, why is it do that? It's the tension from the gums, the circular pipe, and as you blow it up, it has to create tension and holds the tissue at its place. Plus, you're right, the muscle pull it down on the uppers, lowers, and so everything is working for us. The Zen, the invisible force is actually working for us.
Definitely.
Successful.
Definitely so. Okay, so how much time does it take for like covering the dissection?
Well, if it's 1 or 2 teeth, which was what was done in the experiments, we average about 22 minutes.
22 minutes?
22 minutes, that's it. 22 minutes on the average. Okay. Now this is not injection time. This is from the time for the pinhole to the time for the collagen. But 22 minutes on the average. Now it's twice that much if you do the subepithelial connective tissue, but the CTG. All right. But that's because you add another 20 minutes or so of suturing time. So time is actually not very much. Now, some people have to practice a little bit to be able to do it at their proficient rate, but you can see once you have when you do 10 teeth or 12 teeth or 16 teeth, it goes pretty fast. On the average, if you do 10 teeth, probably about 5 minutes a tooth.
Okay, that's quite fast actually. Okay, so Next, yeah, the collagen strips which we are using, like the one which you are using, they're synthetic ones, right?
It's a it's called it's made from horsey.
Sorry?
It's made from pigs. It's a membrane from pigs, but you can also
Okay.
use membrane that's made from cows. You
Okay.
can use membrane that's so you have those two sources, and they're that's what we use for that. They're non-cross-linked. In other words, they're resorbed in about 6 months completely. There's nothing left over. So we don't use cadaver tissue. We use allografts.
Okay. So any replacement for those collagen strips? If you find any sort of autografts?
Use the autogenous grafts, but we don't have to. If you use autogenous grafts, you have to go harvest it and make another
Yes.
wound. So
Okay. Okay.
in a
Okay.
way, we actually this is autogenous graft in the sense that the tissue that we use comes from the patient.
Yeah,
It comes
totally.
from mesiodistal. It comes from the neighboring adjacent teeth. So it is
Yes.
an autogenous graft,
Okay.
but
Yeah,
it's not
totally.
a free. It's actually the technical name could be pedicle graft. Pedicle graft,
Okay.
where you're a periodontologist, you periodontist, you know that. So pedicle graft is when you move tissue from one side to the other. You take the tissue, let's say from the mesial, and put it on to another tooth. So pedicle graft. So if you think of a pedicle graft, that's what it is actually. Except you do from both sides and the apical. You bring it all down all at one time.
Definitely, sir. Definitely. So I'm actually not a periodontist right now. I'm just an undergraduate, basically.
Oh,
I wish to be one.
yeah, okay, that's wonderful. Wonderful. It's a fascinating field. There's so much going there.
Actually. Yes, sir. So next I have a question. Does this technique work in crowding teeth?
Does it work in what?
The crowded teeth. When we
Crowd-
have the teeth all crowded in mandibular anterior region.
Oh,
So
yeah.
can it work?
Yeah, this is a very good question. It does work, but when it's crowded like that, there's limits to what you can accomplish, because you cannot very freely elevate. If the teeth are crooked like this, it's very hard to elevate the tissue without hitting the papilla. So you have to be satisfied with a lesser amount of full coverage. This you have to disclose to the patients.
Okay.
So on the lower interior where you have crowding, you have to lower the expectation and downgrade the prognosis in terms of root coverage. But you can still accomplish the main goal of something like that is to thicken the tissue. If you can thicken the tissue, which we almost always do as a result of pinhole surgical technique, then you can thicken the tissue, make it keratinize it. They'll prevent it from going down some more, which of course would be critical. But that's where if you look at CT scans, you see hardly any bone on the buccal, on the labial, hardly any bone on the lingual. If the gums keep on going down, you can lose more bone and jeopardize the long-term viability of the teeth. So
Definitely.
to go for lower teeth, when it's severe or it's crowded, our goal changes to only the primary goal, that is to create more attached tissue, thicken the zone of attached gingiva, prevent further. So if we don't get as much root coverage, that's okay. We just have to make sure that the patient understands that with crowding, we can expect less root coverage, or we can expect the same amount of tissue thickening.
Okay, so priorly for the crowding cases, we should priorly go for orthodontics first, and then we can move on to this technique, right?
That's definitely one of the options. The patient doesn't mind having orthodontics done, then you can go ahead and do the orthodontics. Now, you raise a very, very important, interesting issue is when you do orthodontic treatment, you have recession already. Are you liable to make it even worse?
Okay.
Right? You're going to move the teeth, right?
Yeah, definitely.
You have already, right? Let's say the tissue is supposed to be over here. Now the tissue is here. You do orthodontics, what's the chance of it going down some more?
Definitely.
You're inclining the teeth, proclining the teeth. So
Yes.
therefore, there's an argument. This
Okay.
should be, consideration is, should you thicken the tissue first to
Okay.
resist recession when you get orthodontics done? Now, again, it's complicated because if you move the teeth with wires, straight wires, you move it backward lingually, you probably don't have to do any surgery. But if you've got any kind of inclination, using
Definitely.
appliances, you can incline the teeth, you can lose movement. So depending on what the movement is, you should do augmentation of the gingiva, whether you use graft or pinhole surgical technique. But generally speaking, there's always some kind of a proclination involved with orthodontics. So in my view is I would seriously look at making the tissue thicker, heavier, and more keratinized, more attached, that
Definitely.
resist recession during orthodontic treatment.
Okay. Definitely.
Now you have a failure, right? So let's say you made it perfect. You do orthodontics, now it goes down again. So did you fail? Let's say it was 3 millimeters before, you brought it up, was 0 millimeters, right?
Definitely.
Now you finish orthodontics and it's 3 millimeters again. So what happens? Did you fail? No, you didn't fail. Because if you didn't do pinhole, you'll be 6 millimeters.
Definitely. Definitely.
So you brought up a very interesting aspect of pinhole surgical technique in conjunction with orthodontics. It's very fascinating to talk about things like that.
Definitely. And so, like, okay, when you're having a case of frenectomy, like where you need frenectomy on the high frenum sites, so like what you will prefer, first go for frenectomy, then with this technique, or leaving frenectomy aside, will this only work for that case?
Yeah, this is a very good question. When do you do frenectomies when you do pinhole? The good news is we don't have to worry about frenectomy on the upper arch at all. I never had to do frenectomy on the upper arch. We used the pinhole and it works just perfectly. The only time I have to do frenectomy is when the attachment between the lower centrals are very high. If it's very high, I do have to do frenectomy, wait 6 to 8 weeks, and then do the pinhole. Because otherwise, otherwise it does not succeed as well. So now, if the attachment is not on the gingiva, but on the mucosa, then we have no problems with doing the pinhole without doing.
Okay. And with this, I think I'm end up with the technical questions. But yeah, the main question I would like to ask you is, what sort of inspiration you took to invent this technique?
Well, so sometimes ideas come to you when you fail.
Okay.
So I was very fortunate to be taught by one of the foremost technicians in the world of periodontology, Dr. Dennis Shenelak. He taught me how to use the microscope, how to really concentrate and minimize trauma using ophthalmic eye surgery instruments to do periodontal surgery. I learned from him, and I tried to learn from him how to do the subepithelial connective tissue graft. And I was never able to master the suturing technique.
Okay.
And so the last time, this was about 2000, I did my last grafting. I took a piece from the palate, I put it over the right upper cuspid. I did the flip already. I put it on the root, and I picked up the hemostat to suture it, and then I looked down the tooth. It was gone. The specimen disappeared, and my assistant suctioned it with a suction tip. I heard the sound. So now I was sweating. And what do I do now? I can't tell Brother John, I'm sorry I had to cut your palate again, right?
Definitely.
Because my suctioned it. I'm so sorry. So I thought maybe I should go to the amalgam trap and look for it. But that wasn't going to work. So I sweated and sweated. Finally, I remembered I had some cadaver tissue, some allograft that was still in the package. So I was able to put the allograft there and sutured it. and of course I was not good at it, so he still remembers to this day what I did to him almost 20 years ago. He would not let me touch it with any physical technique. I said, "No, thank you, doctor. I'm not going to have that done." So after that, I realized that they triggered me to think, well, there
Definitely.
must be some other way. And I
Definitely.
got to study it, and I said, well, why not do it from where there's more tissue, where it's loose, where to try to fracture way, where there's a tight opening. And so as I did it, I realized as the holes get smaller and smaller, I get better and better results.
Okay.
So when the flap is long, you can use different instruments. Almost anything will. But with the longer the flap, the less the healing. When I was able to minimize the incision, making it to almost a pinhole, then I can get good results. But the instruments are all the bend the wrong way. So this is what led me to invent the instrument. So out of failure, it came this idea how to do things differently. So that's the long long answer to a very short question.
No, that's actually quite amazing, no?
I said thank God for our failures sometimes. It does lead to better things.
Definitely, definitely.
Just
And
like
that
the
has worked for you.
something nice will happen.
Definitely, sir. Like you actually, kept us stunned with all the cases because whenever you were just moving on to the next case, every time unconsciously I said, wow, I mean, the results are quite amazing. You don't need to put into more of the instruments, or even you don't need to tackle with blood much. So that was actually quite amazing. And congratulations for your invention you've done for us.
This is not my invention. This is for everybody. This is what I did. This is what everybody can do.
Thank you,
University,
sir.
I think all around the world, more and more doctors will be doing it. Will be a consideration. Anytime you recommend a class 5 filling, you recommend a pinhole. I think that's the day for that is coming up very soon.
So you don't prefer filling those cervical abrasions with composite or GIC, right? You just fill them with all the gingiva and all the soft tissue there.
Yeah, just put soft tissue on it. Then it's permanent. You put a filling on it, it may fall off, right? And then it doesn't stop the gums from receding some more. So
Definitely.
with pinhole, it's a one-time solution, and that takes care of the problem. So I think it doesn't take that much longer, and the expense is not that much more than the composite filling. So I see that over time, more and more dentists, general practitioners, and the periodontists will be doing this because some general practitioners will be doing a lot of this, doing really, really well as they continue to practice it. Others will do some of it and not do as many, just like implants. Some doctors do a lot of implants, some doctors do less implants, depending on your preference. But everybody knows about implants. I think in time, everybody will know about pinhole all around the world. And we're very happy to join this global seminar and talk to so many doctors all at one time. Appreciate the privilege.
Thank you, sir. Thank you so much for the wonderful session you took. Wonderful session. And thank you for sharing your invention with us, moreover.
It's my privilege and my honor. It's such a pleasure to speak to you. You're a wonderful host.
Thank you so much, sir. So I think with this, we'll move on to the end of the session, and I would like to address all the viewers as well as the participants to reach to the site www.gomha.org for further participation, CE certificates, as well as the speaker's schedule. So with this, we'll move on to the end. And I would like to inform all the participants that yes, we are having a long list of beautiful speakers like Dr. John with us. So stay tuned for further updates. Thank you
very
so much. Thank you so
Goodbye,
much.
everybody. Thank you.
Goodbye, sir. Stay safe.
Thank you so much, Dr. Gungabeep.
Thank you, sir.
All right. Okay.